Lithium. Lithium is an element with the atomic number 3 and the atomic weight is 7. It was discovered by F.J. Cade in 1949 and it is most effective and a common used drug to the treatment of mania. Indications of lithium: acute mania, prophylaxis for bipolar and unipolar mood disorder, schizoaffective disorder, impulsive and aggression, other disorders, premenstrual dysphoric disorder, bulimia nervosa, borderline personality disorder, episodes of binge drinking, cluster headaches. Pharmacokinetics. Lithium is readily absorbed with a peak plasma level occurring 2 to 4 hours after a single oral dose of lithium carbonate. Lithium is distributed rapidly in liver and kidney and are more slowly in muscle, brain and bone. Steady state level are achieved in about 7 days. Elimination is predominantly via kidney. Lithium is reabsorbed in paroxysmal tubes and is influenced by sodium balance. Depletion of sodium can precipitate lithium toxicity. Mechanism of action. The probably mechanism of actions can be accelerates presynaptic reuptake and destruction of cytokeramin like norepinephrine, inhibit the release of catecholamines at the synapse, decreased postsynaptic serotonin receptor sensitivity. All these actions result in decreased catecholamine activity, thus ameliorating mania. Dosage. Lithium is available in the market in the form of following preparation. Lithium carbonate. Lithium carbonate is 300 mg tablet or 400 mg sustained release tablet. Lithium citrate 300 mg per 5 ml liquid. The usual range of dose per day in acute mania is 900 to 2100 mg given in 2 to 3 divided doses. The treatment is started after serial lithium estimation is done after a loading dose of 600 mg or 900 mg of lithium to determine the pharmacokinetic. Lithium. Concurrent use with diuretics, fluoxetine, methyl dopa or non-steroidal anti-inflammatory drug increases lithium reabsorption by the kidney or inhibit lithium exertion, either of which increase the risk of lithium toxicity. Acetazolamide, theophylline, phenothiazide or sodium bicarbonate may increase renal exertion of lithium, reducing its effectiveness. The therapeutic medication serum level of lithium is 0.6 to 1.3 milliequivalent per liter. The causes of an increase in the lithium include decreased sodium intake, fluid and electrolyte loss associated with excessive sweating, dehydration, diarrhea or diuretic therapy, and illness or overdose. Serum lithium levels should be checked frequently after initiation of therapy and then every 1 to 2 months of whenever any behavioral changes suggested an altered serum level. Lithium is classified as pregnancy category D. It crosses the placental barrier freely and has been associated with fetal toxicity. Blood lithium levels. Therapeutic levels of lithium 0.8 to 1.2 milliequivalent per liter for the treatment of acute mania. Prophylactic levels 0.6 to 1.2 milliequivalent per liter for prevention of relapse in bipolar disorder. Toxic lithium level is greater than 2 milliequivalent per liter. Side effects. Neurological. Tremor, motor hyperactivity, muscular weakness, seizure, neurotoxicity. These are the neurological side effects of lithium usage. Renal. In renal, polydipsia, polyuria, tubular enlargement, nephrotic syndrome. Cardiovascular, the T-wave depression. We can see the T-wave depression. Next, gastrointestinal, nausea, vomiting, diarrhea, abdominal pain, and metallic taste. Endocrine, abnormal thyroid function, goiter and weight gain. Dermatological, papular eruption and exacerbation of psoriasis. Side effects during pregnancy and lactation. Tetragenic possibility, increased incidence of Epstein anomaly. Epstein anomaly means distortion and downward displacement of tricuspid valve in right ventricle when taken in first trimester. It secretes in milk and it can cause toxic in infant. Lithium toxicity occurs when serum level is greater than 2 mg per liter. What are the signs and symptoms of lithium toxicity? Ataxia, nausea and vomiting, impaired memory, impaired concentration, nephrotoxicity, muscle weakness, convulsion, dysarthria, lethargy, confusion, coma, nystagmus. These are the signs and symptoms of lithium toxicity. What are the intervention or management of lithium toxicity? Discontinue the drug immediately. Next, for significant short-term injection, residual gastric content should be removed by induction of emesis, gastric lavage and absorption with active charcoal. If possible, instruct the patient to ingest fluid. Assess serum lithium level, serum electrolytes, renal function, ECG as soon as possible. Maintain a fluid and electrolyte balance. In a patient with a serious manifestation of lithium toxicity, hemodialysis should be initiated. Contraindication of lithium uses: cardiac, renal, thyroid or neurological dysfunction. Presence of blood dyscrasia during first trimester of pregnancy and lactation is contraindication of lithium usage. Severe dehydration, hypothyroidism, history of seizure. What are the nurses' responsibility for patient receiving lithium? The pre-lithium workup, a complete physical history, ECG, blood studies, urine examination must be carried out. It is important to assess renal function as renal side effects are common and the drug can be dangerous in an individual with compromised kidney function. Thyroid function should also be assessed as the drug is known to depress the thyroid gland. Lithium must be taken on a regular basis, preferably at the same time daily. When lithium therapy is initiated, mild side effects such as fine hand tremor, increased thirst, urination, nausea, anorexia may develop. Most of them are transient and do not represent lithium toxicity. Serious side effects of lithium that necessitate it discontinue, including vomiting, extreme hand tremors, sedation, muscle weakness, and vertigo. The psychiatrist should be notified immediately if any of these effects occur. Since polyuria can lead to dehydration with the risk of lithium intoxication, patients should be advised to drink enough water to compensate for the fluid loss. Various situations may require an adjustment in the amount of lithium administered to a patient, such as the addition of a new medicines to the patient's drug regimen, a new diet, or illness with fever or excessive sweatness. In this connection, people involved in a heavy outdoor labor are prone to excessive sodium loss through sweating. They must be advised to consume large quantities of water with salt to prevent lithium toxicity due to decreased sodium level. If severe vomiting or gastroenteritis develop, the patient should be told to report immediately to the doctor. These conditions have a high potential for causing lithium toxicity by lowering serum sodium level. Frequent serum level Frequent serum lithium level evaluation is important. Blood for determination of lithium level should be drawn in the morning, approximately 12 to 14 hours after the last dose was taken. The patient should be told about the importance of regular follow-up. In every 6 months, blood samples should be taken for estimation of electrolyte, urea, creatinine, a full blood count, and thyroid function test. Monitor the suicidal patients, especially during improved mood and increased energy level. Administer the medication with the food to minimize gastrointestinal irritations. Instruct the client to avoid excessive amount of coffee, tea, cola, which have diuretic effect. Do not administer diuretic while the client is taking lithium. Instruct the client that he or she may take a missed dose within 2 hours of scheduled time. Otherwise, the client should skip the medication missed dose and take the next dose at the same scheduled time. Instruct the client to therapeutic response to the medication is noted in 1 to 3 weeks. Monitor ECG, renal function test, and a thyroid test. Ensure that these tests are performed before the start of therapy. Instruct the client taking lithium to maintain a fluid intake of 6 to 8 glasses of water a day and an adequate salt intake to prevent lithium toxicity. Lithium's Once again we will discuss about the signs and symptoms of lithium toxicity. Mild toxicity. Mild toxicity. Serum lithium level of 1.5 milliequivalent per liter. Apathy, lethargy, mild ataxia, slight muscle weakness, coarse hand tremor, diminished concentration. These are the mild toxicity. Moderate toxicity. Serum lithium level is 1.5 to 2.5 milliequivalent liter. Nausea, vomiting, severe diarrhea, mild or moderate ataxia, slurred speech, tinnitus, blurred vision, muscle twisting, irregular tremor. Severe toxicity. Serum lithium level greater than 2.5 milliequivalent per liter. Nystagmus, muscle fasciculation, deep tendon hyperreflexia, oliguria, anuria, impaired level of consciousness, tonic-clonic seizure or coma leading to death. Intervention. Withhold lithium and toxicity and notify the HCP. Monitor vital signs and level of consciousness. Monitor cardiac status. Prepare to obtain sample to monitor lithium electrolyte, blood, urea, nitrogen,